Welcome. My name is Kelly Condon, and I am the Program Coordinator for the Texas Oncology Foundation. First of all, thank you all for joining us for today's presentation. We have Dr. Reagan Street with us today, and she's going to lead our discussion on babies after cancer. I just want to go over a few things before we get started. First of all, I just want to tell you a little bit about the Texas Oncology Foundation. We are dedicated to providing support to cancer patients in the communities where they live, work, and receive treatment. Survive and Thrive programs just like this and our symposiums around the state are just one of the ways that we are active in your communities, providing resources and support to everyone involved in the cancer journey. We also want to thank Texas Oncology for their continued support and partnership with these programs. I also would like to just kind of take a poll and see who we have on this call with us today. So you are going to see a quick poll question come up on your screen and just click on whichever applies to you. We want to know, do we have survivors, caregivers, healthcare providers? Maybe you're a few of both, or are you an other? So I'll give you a few minutes to respond. Awesome. So it looks like we are predominantly healthcare professionals on this call today, which is great. Next, I just want to go over a few housekeeping tips in case you are experiencing any issues during this presentation. If you are having anything like your window disappearing or the slides are not advancing, we've found that closing out and reopening your webinar window will usually fix the issue. If you are experiencing problems with your audio, the solution is to call into the webinar and listen over the phone. If you see your control panel that has popped up on your screen when you logged in, you can go to the audio tab on there, and then you can select phone call, and a number will populate that you can use to call in. If you have any questions throughout this presentation for Dr. Street, please utilize the questions tab. Again, it's located on that control panel. We want to know your comments, we want to know your questions for her, but we are going to respond at the end of the presentation. So keep them coming throughout the whole presentation and we will respond at the end. Lastly, this webinar is being recorded and the online archive will be available for viewing after this live version. So if you ever need to go back and reference something, the resource will be there. This recording will be sent to everyone in a follow-up email, and it will also be available on our Texas Oncology Foundation website, which is texasoncologyfoundation.org. You find the programs tab along the top, and then Survive and Thrive webinar archives will be on the left, and all of our past presentations are stored there. As I mentioned earlier, we are very excited to have Dr. Street on this call with us today and presenting. Dr. Street serves at the Texas Oncology sites in Bedford and in Fort Worth, and she specializes in gynecological oncology. Dr. Street, thank you for taking time to share with us today about fertility options available after a cancer treatment. And I'm going to hand it over to you now.
Thank you. Okay, hi everybody. So I'm a GYN oncologist. Please ask any and all questions. I guess we're going to do it afterwards, but please don't hesitate. I'll answer pretty much anything. Can somebody confirm that y'all can hear me? Kelly?
Yes, we can hear you.
Okay, good. Okay, cool. I also made this presentation obviously with multiple different audiences in mind. So if I talk over or under, an education level, just ask that question in the final two. Okay, we're going to talk about cancer and reproductive age. Okay, hold on a second. This is my first webinar too. So I'm working on these different things. Okay, so we're going to talk about cancer and reproductive age women, fertility challenges, fertility preservation options, and then outcomes. Uh-oh. Hold on, technical difficulty. It was? Okay. So 20% of cancer in general is diagnosed in the United States under age 50. And just breast cancer alone, which of course is where most of the research is in, 70,000 women with breast cancer are diagnosed in their fertility years, ages 15 to 39. Not that 39 is a fertility year, because it's really up to 50 or so, especially with IVF and all the stuff we have now, which I'm very thankful for because I just turned 40 with no babies, so just FYI. There's significant improvements in treatments, which has led to that increased fertility preservation and different options. The other good thing is we're winning this whole cancer thing, where we have a decrease in our U.S. cancer death rate about 26% between 1991 and 2015. So there's going to be continued more survivors, and these are obviously going to be treatments and options that they need. Again, like I said just now, age 12 to 51 is your average reproductive years, and 1 in 250 women are cancer survivors in that age group. Various cancer treatments can decrease or even eliminate fertility. But even if that fertility is completely eliminated, of course, there's always things like adoption, surrogacy. We're going to talk about those too. You also have to address all this before treatment. So it's no good to start your treatment and then go see the infertility doctor. So an infertility doctor is somebody who has been to an OB-GYN residency, so med school OB-GYN residency, and then they have specialized in reproductive endocrinology and infertility after their OB-GYN residency. So seeing your OB-GYN is not enough. So when you get a cancer diagnosis, it's really important to get to that infertility doc before you start your cancer treatment so that they can address options for you based on your age, health, et cetera, what the cancer is, et cetera. Of note, there are certainly fertility challenges with males too. So certainly if anybody's, husband or male patient goes, gets a testicular or, even some brain tumors because they're related to hormone production, those are things that should be addressed again before treatment starts. So as I said earlier, patients are living longer with our current therapy. 90% of young cancer survivors are long-term survivors. So, they're getting to these, we're talking even young patients like less than 20, they're getting long-term survival rates. And so we want them to have a normal, healthy, fulfilled life, kids, grandkids, all of that. Now, there is some thought in some studies that fertility preservation may compromise survival. That is mostly based on length of time it takes to do fertility preservation and various things like hormone therapy for uterine cancer, which we'll talk about in a little bit. Most of the time, fertility preservation is quick and does not compromise survival. So I don't want that to ever be a factor in anybody seeking evaluation with an infertility doctor. You got to at least go talk to them. So as you all know, different cancer treatments, surgery, radiation, chemo, hormone therapy, biologic therapy. Biologic therapy is all the new stuff, the immunotherapy that's kind of coming out, rapid fire. We don't know a lot about biologic therapy and its effect on fertility, but we do know a few of the bigger ones can cause issues. So fertility, there's lots of different fertility challenges. Cervical incompetence makes it where the cervix can't hold on to the pregnancy. So you get pregnant, but then you can't make it to, a viable pregnancy, which is we generally consider 23, 24 weeks. This can happen with cervical cancer treatment. If we take just your cervix and we leave your uterus, you can still get pregnant, but sometimes you can't hold that pregnancy in. Certainly if you've had any kind of surgery or radiation to your uterus, obviously if your uterus is gone, you're definitely not going to be carrying a baby. Radiation damage can certainly affect your ability to carry a baby. So pelvic radiation. Ovaries, if you have an ovarian cancer, they generally get treated with surgery and chemotherapy, very rarely radiation. But the ovaries can get damaged by radiation for other kinds of cancers in the pelvis too, and certainly for chemotherapy and everything in every kind of cancer. Well, not every kind of cancer, but a lot of kinds of cancers. We're going to talk specifically about chemotherapy that damages the ovaries. And then there's also fertility challenges that have nothing to do with cancer. So meaning if you got, if you didn't have any kind of cancer at all, you could still have age-related fertility challenges, endometriosis, anatomy distortion, maybe you had an infection in the pelvis at some point and the tubes got dilated, or endometriosis can cause that. So there's lots of different, or fibroids, lots of different factors that have nothing to do with your cancer that complicate all of this tenfold. So surgery for non-pelvic cancer, meaning like breast cancer, you have surgery for breast cancer, you're not going to have an effect on your pelvis, on your ovaries, uterus, or cervix. Now, having said that, if you have brain surgery for like some kind of a brain tumor, you can certainly get effect on the pituitary gland, which has an effect on hormone production and regulation. So that could be an effect. And then pelvic surgery, of course, for gynecologic malignancies may require ovarian, uterine, or cervix removal, and obviously all three of those will affect your ability to carry a baby. So we are now doing fertility-sparing surgeries pretty much every chance we get. So specifically for cervical cancer, a lot of women are diagnosed at less than 40 years old. If they're early stage, stage 1A1, which is a very small tumor, they can be treated with conization, which means taking off just a portion of the cervix, so not the whole cervix. Stage 1A2 to small 1B1 can be treated with what we call a radical trachelectomy, and we also take nodes when we do that. But there's different things, there's different factors that we want to make sure you have to make sure that your recurrence risk is low enough to do that kind of surgery. Because you certainly don't want to compromise recurrence risk in an effort to, get pregnant, because then you have a bigger problem if you're, pregnant and going to die an early death from this kind of a thing. You don't want that, obviously. We place it, when we do that, we take out just the cervix, the tissue lateral to the cervix, and we leave the uterus. And then we put this thing called a cerclage, which is a big fat stitch in the cervix, so where the cervix and the uterus have been resected. So where the cervix is gone and the uterus is there, that hole gets closed with what we call a cerclage. So we generally say wait 6 months prior to getting pregnant, and 2/3 of those will get pregnant if they don't have any other factors, and those 2/3 of those will get to the third trimester, which we consider very good. Third trimester being 28 weeks or more. 28-week babies do very well with current medicine. There's also ovarian preservation and translocation. So sometimes if we take your uterus out, do radical hysterectomy for cervical cancer, we can move those ovaries out of the field of radiation and sometimes get eggs out of that, and I'm going to talk about that in a little bit, for future pregnancies. If the uterus is radiated for cervical cancer, you can't carry a baby in that situation, but you can get a surrogate. Ovarian cancers, so there's 3 different kinds of ovarian cancers: germ cell tumors, sex cord stromal tumors, and epithelial ovarian cancer. Epithelial ovarian cancer is your garden variety ovarian cancer. That's what most people think about when they think about ovarian cancer. But young people get all of these. Most people require chemotherapy for epithelial ovarian cancer in addition to their surgery. But if we can do fertility-sparing surgery, so if it's isolated to one ovary, we can take out that ovary. We can do lymph nodes, omentectomy, and biopsies, which all of that is what we call staging. And then ideally we can save the uterus and the other ovary if we are at a stage 1. Now, having said that, the most common recurrence is in the contralateral ovary. So we certainly say if you get pregnant, once you're done having babies, we got to get that other side out. And again, in this situation, 2/3 of those get pregnant. We recommend waiting 12 months, and that's more about recurrence risk than it is about the surgery itself, because we want to know that you're going to get, further out from the disease itself so that you can have a healthy pregnancy and not have a recurrence. So radiation, we briefly talked about this a second ago. Radiation doses cause ovarian cancer, and the amount that it takes to cause, ovarian failure, and the amount that it takes varies by age. So the younger you are, the more the ovaries can be hit with radiation. The older you are, the ovaries are not as I'm trying to think of the word, they can't bounce back as well. So, for example, CT scans have very small amounts of radiation. Environmental factors contribute to 50 to 100 milligray of radiation by age 17. So that means just living your life. 1 gray is 1,000 milligrays, so it takes a lot to get to. I mean, you basically have to have full radiation to get to where you're going to have an ovarian failure. So even if you have 20 CT scans in 5 years for your breast cancer or whatever, you're not going to get ovarian failure from that. Radiation doses for cancer treatment, so high dose obviously for the cervix, 40 gray for the breast. Most of that's not scattered down into the pelvis. So if you're just getting radiation for breast cancer, your uterus, tubes, and ovaries should still be fine. Most recommend waiting 1 to 2 years after breast radiation to become pregnant, but again, that's due to concern for tumor relapse, not because of the radiation itself. Now, radiation before puberty, so if you're a young child with, say, a Ewing sarcoma or something in the pelvis, then they radiate for that. And because it's, the uterus hasn't really grown yet, it does increase your miscarriage, low birth rate, premature birth rate, but you still can get pregnant in that uterus. And then again, I said earlier, radiation to the brain affects the pituitary gland. Well, radiation and surgery can affect the pituitary gland, which is what is responsible for the hormones that lead to your ovaries that cause them to start ovulating, etc. So chemo, pregnancy during chemotherapy is not ideal. Now, there are certainly situations where people are diagnosed during pregnancy with their cancer and then we give them chemo, but you don't want to start your chemo and then get pregnant while you're on chemo. So hopefully that makes sense. So we generally want to wait till 6 months or so after to allow the mature eggs to get out of there before we start trying to get pregnant. Ovarian insufficiency or failure rates after chemo depend on the protocol. So it depends on what drugs you get. Again, important factors, age. Younger women, of course, have the best chance of pregnancy. And it also depends on your drug type, your dose, and how many different drugs you got for your chemo. So chemotherapy-related ovarian failures, high probability drugs are cyclophos, chlorambucil, and dacarbazine. These are alkylating agents, and they're the worst. Then we've got some that, like cisplatin's a pretty common one. It's a probable ovarian insufficiency or failure. And then you have some that, especially for treating some of those ovarian cancers, we use bleomycin or methotrexate. We use certainly doxorubicin for breast cancer. These are low probability, or some of them are a little bit unknown, but low probability types to cause ovarian failure or insufficiency. So it very much depends on what drug you got, how much you got, how many cycles. So immunotherapy is what I briefly discussed. Biologic therapy is the same; those are used interchangeable. These are new. They're coming fast, and we don't know 100% what these will do. We certainly know that Gleevec can cause birth defects, and we certainly know that Avastin can cause ovarian failure. Avastin's probably been around for maybe 10 years. But as we continue to have new drugs introduced, it's going to take a while before we figure out what they do to fertility. Bone marrow stem cell transplants. These are high-dose chemo and high-dose radiation, and they do cause permanent ovarian failure. And so, again, as we've talked earlier, you've got to address those fertility options prior to treatment. So, fertility, the main idea is that fertility and or family options exist for everybody. They may not be ideal, but certainly they're there. Conservative surgery, like we talked about, chemical fertility preservation with GnRH agonists, which is Lupron or Zoladex, while getting chemotherapy. The infertility docs consider that experimental and say that it should only be done on trial. I do know that there are certain people that are certainly getting that while they're on chemo. So that's definitely happening, not on trial. But in general, the infertility docs say it shouldn't be considered a good way to do it. Hormone therapy for endometrial cancer. So sometimes, and I'll talk about this a little bit more later, actually. I think I've got another slide on that, so I'm going to skip that for right now. Egg, sperm freeze prior to the treatment, embryo freeze prior to treatment if you've got, man and woman. Ovarian tissue preservation is, again, experimental. Certainly donor eggs, donor embryos. So say you had to have your ovaries out for ovarian cancer, but you kept your uterus. You can carry a baby with donor eggs or embryos. And then, of course, a surrogate carrier, which means somebody else is carrying it for you. And then, of course, adoption. So the GnRH agonist, again, during chemo, theoretically it suppresses eggs so that the chemotherapy doesn't kill those. There are studies that show that it decreases the ovarian insufficiency rates and increases the pregnancy rates. But again, the infertility docs are not completely on the same page with that. So they really want to have those conversations with these patients before they start chemo. Hormone therapy for endometrial cancer. So a lot of endometrial cancer is diagnosed at under age 40, and it's a situation of obesity, infertility, irregular menses, and sometimes, so it's a factor of too much estrogen. So sometimes we can do conservative therapy with progesterone and basically balance out those hormones in the uterus. There are certainly ideal candidates, grade 1. You certainly wouldn't do this for a grade 3 or a high-grade cancer. But a grade 1, 2, with no enlarged lymph nodes on MRI, no deep invasion, that's very much an option to try. And we generally use either an IUD or Megase, which is just a pill. And then we rebiopsy after 3 months. And then depending on what that shows, we may continue it. And you can continue, if they don't get pregnant, keep biopsying them every 3 to 6 months until they do get pregnant. This this is significantly better with weight loss. And even there have been studies that have shown bariatric surgery helps with this. So going that far with weight loss really makes a difference in endometrial cancer. And then certainly after you get done with childbearing, we get that uterus out. So egg and embryo freeze. So it takes about 2 weeks for a freeze cycle. And there have been multiple studies that have shown no difference in diagnosis to starting chemo, even if there's an egg freeze cycle performed. In other words, while you're getting insurance coverage, while you're getting your port placed, while you're getting all these different things happening, you can get your egg freeze cycle in that amount of time and still start chemo at the same time that you would have started regardless of getting an egg freeze cycle. So we don't want people to not do this or not go through the infertility doctor because they're in fear of not being able to start their chemo treatment in some amount of time. So that's really important, is you don't want to get so scared by your cancer that you don't think about future options like this. It is 25 plus injections, so you got to have motivation to do that to yourself. I have done a egg freeze myself, and it's a lot of shots. I mean, I give people shots and cut on them every day, and when you're giving it to yourself, it's a lot. And it hurts, but it's worth it for the future, options. The cost is extensive. Some grants are available that help with this to offset the costs, and some clinics offer discounts, and the infertility docs will help you with that. It does require surgical fertility, meaning that they got to get those eggs or embryos back in there. So it's generally IVF, and so that's that's another procedure after you're done with all your cancer treatment. Embryo freeze gets you a 50% live birth rate. So you freeze 2 eggs or 2 embryos, you're going to get theoretically one good baby out of that. Egg freeze, 5% live birth rate per egg. So that's much lower. So they generally want you to have 12 or so eggs to guarantee a baby. That gets hard as you get older. Ovarian tissue preservation basically means taking a little piece of the ovary out, freezing it, and then, or preserving it, cryopreserving it, and then putting it back in. There unclear success rates, but there have been live births, more than 200 live births from that. So it can work, but we don't know exactly if it works, 1 in a million, or we don't know. It does require 2 surgeries because you got to take it out and then put it back in. And then, of course, our alternative options. So gestational carrier, which is certainly limited by cost and supply, egg and embryo donors, and, of course, adoption. Pregnancy outcomes. So there's not any increase in congenital anomalies if you get pregnant after cancer diagnosis and treatment in general. There's certainly limited data, but there's no increasing recurrence either. So most things are studied in breast cancer. So whether or not you get pregnant after you've had your breast cancer treatment does not increase your recurrence risk. Now, the pregnancy rate in most of those studies for breast cancer is significantly lower than for people that have not had breast cancer. So it certainly has an effect on, all the treatment has an effect on your ovaries, of course. We also know that estrogen stimulation during your IVF doesn't increase your recurrence risk. So it's okay, you had your cancer and you're worried about getting estrogen, it's okay to get it during your IVF. It's not going to increase your risk of recurrent cancer. And of course, egg and embryo preservation are more successful than anything as far as fertility, better than GnRH agonists during chemo. You want to get those eggs and or embryos out. Now, one concern is if you're going to have a high-risk pregnancy. Not necessarily. Now, if you have had radiation to the chest or some kind of cardiotoxic drug, certainly that would be that would warrant an evaluation by cardiology and probably maternal fetal medicine, which are the high-risk pregnancy docs either prior to pregnancy or early in pregnancy. And you also want to continue your oncology surveillance. So if you're getting surveillance every 3 months for whatever your cancer is, you want to continue that during your pregnancy. It's a lot of doctor visits. So genetics. So, most breast cancers, all ovarian cancers, any endometrial cancer under 50, any colon cancer under 50, all of those get genetic testing. Inherited gene mutations are in the egg or sperm at fertilization. So we can do, we not being me, we being the infertility doctors, will do pre-implantation genetic testing to test for those things. So that they know that you're a BRCA1 positive patient, they can test your embryo for that to see. And so if they have, 5 or 6 little embryos, they can test out and know that whichever one doesn't have it or does have it, and then they can implant the one that doesn't have it. Because you don't want to, of course, pass it on if you can help it. So this is a good way to evaluate for that. And then they can test it immediately. Like they can do the embryos immediately, test them, and then freeze them, and then you use them later. So it's not like you have to test them right before you get pregnant. Like you can test them all and then freeze them and then use them later. So hereditary breast and ovarian cancer is the one that we mostly hear about, and that's BRCA. And then Lynch syndrome is colon endometrial generally, but of course there's others as well. And then Leigh-Fermini syndrome is a type that can do breast cancer also. And these are all ones that we can test with that pre-implantation genetic testing. So the bottom line is we want all patients to go to the infertility doctor. So REI is Reproductive Endocrinology and Infertility Doctor. We want them to go as soon as they can for counseling and to avoid delays in treatment. And you want to delay getting pregnant after treatment until at least 6 months or so to get all those damaged eggs out. And you've got to recover from the side effects of treatment. I mean, not a lot of people who want to go through 6 months of chemo and then get pregnant 5 minutes after that because they've been feeling bad for so long they kind of need a break. Not that all pregnancy feels bad, but y'all know what I mean. Anyway, and you've got to have an acceptable recurrence risk. And that's certainly a conversation between, your oncologist and you, and family if appropriate. And that's it.
Dr. Street, thank you for sharing.
Sure. Thank you for having me.
Absolutely. Well, I have been writing down some questions of my own, and so I just want to encourage our audience, if you have questions for Dr. Street, please use the question tabs on your control panel, but I'll start the conversation and you guys just chime in. So one thing I really like that you brought up was talking with a fertility specialist not only before but during your treatment. Can you just elaborate and kind of give some tips on how they can get connected with those fertility specialists?
Either through your OB-GYN or through your oncologist. I mean, at this point, every oncologist should have a fertility doc in their back pocket. I mean, in my opinion. So, but your OB-GYN for sure does. Your OB-GYN for sure has a fertility doc in their back pocket, somebody that they sent to.
Great. Fertility, the way you talk about it, it seems like it is a much more prevalent topic among oncologists now. And you were talking about, preventative surgeries are already in place while treating the cancer. And so that's encouraging. And I feel like that makes the conversation a lot easier to bring up as well. Yes.
And these are new things in the last 10 to 15 years, probably more like 10 years. We just didn't do this stuff 15, 20, 30 years ago. But now we've got new options. And, obviously that's what medicine's all about, is evolving and helping people as best as you possibly can.
Absolutely. When you were talking about egg and embryo freezing, how long are those viable to use later on?
Forever. So if they're viable, they're viable forever. Yeah.
Okay.
So you could freeze an egg or an embryo now, and your great grandchildren could use them.
Oh my gosh. Okay, I did not realize that.
Yeah. Once it goes in the freezer, it can stay forever.
It's good. All right.
It's not like just a freezer. It's like a.
Yeah.
It's not. Y'all can imagine. It's not going in your freezer next to your ice and your ice cream.
And then along those lines, you were talking about ovarian tissue preservation. Are all people good candidates for that, or is that kind of a specific group?
So first of all, it's very young people, and second of all, not very many people are doing this. So this is definitely considered still experimental. We are not doing this. I think it will probably come eventually. It's maybe a few years out.
Okay. And then I thought it was so interesting when you were talking about the genetic testing and already being able to see which of your eggs might carry on that cancer gene. Has there been any, if people are getting pregnant after cancer and maybe it's not with a frozen embryo, is there an increase in passing on that gene?
So BRCA and Lynch both pass 50%. So there's 50% chance of, if you have a BRCA gene, there's a 50% chance you're going to pass it on. So you do want to do that genetic testing before, because 50% is really high, obviously.
Absolutely. Amazing. Well, those are kind of the questions that were bopping around in my head. And we don't have any more right now. So is there any last minute things that you want to share or comment about?
No, thanks, y'all.
Awesome. Well, thanks again for taking time with us and just giving us some options to think about.
Sure.
Thank you all for joining us today. Please stay connected with our foundation. Visit our website, like us on Facebook. We have upcoming events. We will be continuing on our Survive and Thrive symposiums around the state. We will be in Arlington on September 21st, in Houston on October 12th, and in Beaumont on November 2nd. So look out for our events. We're coming around the state all this fall. We will also be in Longview and Mount Pleasant last weekend in September and first weekend in October for 5K runs. So if that is of any interest to you, please go check out those events as well. And as we bring this webinar to a close, a survey is going to open on your screen. Please take a moment to provide us with feedback on today's presentation, as well as topics you'd like to see covered in future webinars. So thank you all again for joining us. And Dr. Street, thank you again.
Thank you.
Have a great afternoon.
Y'all too.